COVID-19. How does this coronavirus, SARS coronavirus 2, kill people? Why does it kill some people but not others? Well, it is mainly transmitted by respiratory droplets and through contact, and it gets into our mucosa of our mouth, our nose, and our eyes. Although less common, it can also be transmitted through aerosol, meaning airborne. Most likely when you have people in an enclosed space, such as an elevator, or when someone sneezes or coughs without covering their mouth, especially in an elevator, and then someone can inhale that aerosol, and that's how that is mainly transmitted when it's done through aerosol. But most of the transmission is going to be through respiratory droplets and or through contact. This virus attaches to cells in our body by the ACE2 receptor. This ACE2 receptor is only located on certain cells in our body. It's on our tongue, it's in our nose, it's in the back of our throat, and it's in our lungs. Specifically, within the lungs, it's only located on our type 2 alveolar cells. What's that, you ask? Let's take a closer look at our lungs. All right, so we're going to deep dive into this PowerPoint that I created, and we're going to start off by getting into the lungs. Here is our windpipe, aka the trachea. This is going to divide into our right mainstem bronchus, and this is our left mainstem bronchus. And just like branches on a tree, these are going to keep branching into smaller and smaller branches. Same thing with this lung, and then eventually it's going to branch so small that it's going to become like the leaves on the tree. And this is called the alveolus here. Alveolus is mainly comprised of type 1 alveolar cells. That is what actually forms the structure of the alveolus here. But that's not everything. The other kind of cell is the type 2 alveolar cell, and that's this thing right here. And that's important because that's where the ACE2 receptor is located within our alveoli. This right here is a macrophage. This is a kind of white blood cell. Macro means big, and then phage means to eat. This yellow stuff right here is called surfactant. It's like lubrication for the alveoli. It's very important to keep the alveoli open, but also it's important to make sure that the alveoli is not too stiff. So that's lubrication, makes it nice and smooth. Here we have a fibroblast. This is a cell that is responsible for maintaining the structure of the lung tissue, and they also do maintenance. Shout out to all the maintenance people, custodians, thank you very much. This right here is a capillary. This is a pulmonary capillary, and you can see it's going to come in close proximity to the alveolus, and this is where gas exchange occurs. So when we breathe in air, it comes down here, the oxygen, and air is going to diffuse through the type 1 alveoli into our capillary and go into the red blood cell. And carbon dioxide is going to go from our red blood cell. Carbon dioxide is CO2. It's going to diffuse from the red blood cell through this membrane, then through this membrane, and then into the alveoli, and then we're going to exhale that CO2. It's going to go out that way. Now, besides this red blood cell you see, you also have a neutrophil here. That's another kind of white blood cell. Think of a neutrophil as like the police or the military. They're just coming by here and they're just making sure everything is all good, not needed here, and then just going to keep on moving through here. You'll notice this white blood cell, this neutrophil, is much bigger compared to the red blood cell. Now, let's look at how the virus gets into this alveolar cell, this type 2 alveolar cell. As I said before, the type 1 alveoli don't have these ACE2 receptors, but the type 2 do have them. So the coronavirus is going to come down to the type 2 alveolar cell and is going to go up to the receptor and be like, hey, you want to have some fun? And then this ACE2 receptor is like, well, it's a good fit. It's a good bind here. So lets the coronavirus into the house, and the next thing you know, he's asking if she wants eggs for breakfast. So at this point, the coronavirus enters the cell, the type 2 alveolus, and we have the RNA of the virus here, and then it's going to unravel and it's going to make copies of its own messenger RNA, and then it's also going to use that messenger RNA that it has and use the cell machinery to make proteins. So it's going to make the proteins for its spike protein, it's going to make different parts of proteins for different parts of its cell. The bottom line is it's going to replicate itself and make multiple copies, and then this new coronavirus that's formed is going to go and attack other type 2 alveolar cells. Now this is important because it's going to trigger a cascade of reactions. It's going to trigger this cytokine storm, but it's also going to downregulate this ACE2 receptor, which is very important, and I'll explain that in a little bit. At some point, the nucleus of the cell, which is right here, is going to recognize that this whole process of the virus replicating itself, this is not supposed to be here. This is a foreign invader, and it's going to trigger a release of chemicals that send a distress signal. This is the initiation of the cytokine storm. The other thing, this virus is affecting this nucleus when it comes to the downregulation of this ACE2 receptor. This is an enzyme in the body that serves a specific purpose, and we're going to talk about the importance of that in a little bit. So as I mentioned, the distress signals that are being sent in the cytokine storm, it's going to be IL-1, IL-6, IL-8, and IL-29. These are all very important, but I want you to pay attention to IL-6. Now, IL stands for no, close Ken, but it's actually interleukin. The downregulation of this ACE2 receptor is so important because, as if the cytokine storm isn't bad enough, triggering all that inflammation that's about to happen, the other thing is it does this. When there's downregulation of the ACE2, there's less ability to convert angiotensin 2 to angiotensin 1-7. And there's also less ability to convert angiotensin 1 to angiotensin 1-9. Why is this important? Let's take a closer look. Angiotensinogen is a protein made in the liver. Renin is a protein made in the kidneys. Renin is an enzyme that converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by this enzyme, angiotensin converting enzyme. These two molecules, by way of the ACE2 enzyme, are converted to angiotensin 1-9, angiotensin 1-7. This is very important because this pathway here is going to lead to vasodilation, meaning the blood vessels, the pulmonary arteries, get dilated. When there's more angiotensin 2 and less angiotensin 1-7, this is what happens. The angiotensin 1 receptor gets stimulated, and that leads to vasoconstriction, leads to more inflammation and more fibrosis. So we want the balance of this cascade, this series of reactions, to be shifted more towards this way and less towards this way. But that's not what's happening with this virus. In between the cytokine storm and between the downregulation of this ACE2 enzyme, and what ultimately happens is you have more angiotensin 2 in the lungs and less angiotensin 1-7. This is going to trigger a crazy, chaotic reaction within the lungs. Okay, back to our type 2 alveolar cell here. Remember when we were talking about this, things were normal before, but now they're not so normal. Remember we talked about this cell releasing these cytokines, this IL-6, this IL-8, this IL-1, IL-29, and also the downregulation of the ACE2. Well, that's going to trigger all this chaos to happen. The red blood cells come in here, but guess what? Remember that neutrophil we talked about? It's actually attracted to these chemicals that are released, so it's going to find its way into this alveolar space, and here it is here. And it's going to release more chemicals, leukotrienes, PAF, oxidants, proteases. These all destroy stuff. They destroy cells. Remember this guy, the macrophage, means big eater? Well, guess what? Just like Guns N' Roses, he's now got an appetite for destruction. He's going to release TNF alpha, IL-6, IL-8, IL-1, destroying stuff, just eating everything in its path. The alveolar wall here, that's going to be destroyed through all this destruction. This membrane here of the endothelium, that's going to be destroyed. Fluid is going to seep from this capillary into the alveolus. All this yellow stuff here, that's all fluid. All this pink stuff, that's hyaline membrane. That's protein deposition. Proteins are being deposited there. And also because of the destruction in this membrane here, the red blood cells, they're going to leak into there. That's called bleeding. This fibroblast is going to make more destructive stuff, more cytokine storm. IL-8, it's going to lay down procollagen, which is the precursor to collagen. That's going to lead to scarring in the area. This is all bad stuff. This is what it looks like underneath the microscope. This is normal. This is normal alveoli underneath the microscope. This is what it looks like with ARDS from COVID-19. This was actually taken from a patient who died of COVID-19. And you could see what I was talking about, that hyaline membrane formation, that deposition of all those proteins and cellular debris. It's all crazy here, right? And then you have lymphocytes, the white blood cells in here, and then you have, this is the other lung, the same patient. You have a big macrophage here. And all these lymphocytes spread throughout with this hyaline membrane deposition. This is chaos. This looks like the end of Avengers Endgame in that final scene. This is a normal chest x-ray, okay? Here we have the heart. We have the vertebrae here. We have the ribs, okay? We have the diaphragm. That's the biggest muscle that controls your breathing. Okay, you have the scapula here, the collarbone, the clavicle there, all right? Now all this black, that represents air. That's normal. This kind of white hazy stuff, that's the pulmonary blood vessels. Okay, that's all normal. Then this happens from a COVID patient with ARDS. Look at all that. There's hardly any black there. All the air is gone, all right? How is that oxygen supposed to get into or through the alveoli into the pulmonary capillary? How is that supposed to happen? This is a CAT scan of a normal person, normal lungs, okay? So they're laying down on their back here, all right? And then you're standing at their feet and you're looking towards their head. And this is a thin slice and cross section. The black stuff represents air, and this white stuff is actually the pulmonary vessels, the pulmonary arteries and pulmonary veins. All right, so this is normal. This is the CT scan of someone with ARDS. There's some normal lung in here, but there's also areas of ground glass opacification. That's partial opacification or partial filling of the alveoli. And then you see it's more dense here. Okay, that's complete opacification. That's complete filling of the alveoli with fluid and inflammation. Now, as if this isn't bad enough, where the alveoli are either partially or completely filled with fluid and inflammation and protein and all that stuff, well, what I didn't mention to you before was these purple dots here. That represents very tiny thrombi, very tiny clots that form as a result of all this inflammation. What does that do? That's going to clutter those little capillaries, and that's going to clutter the blood flow that goes to the lungs. And as if that's not bad enough, there's another thing that's very, very bad when it comes to ARDS, especially in COVID-19 patients. And that has to do with pulmonary hypertension, meaning the pulmonary arteries that go to the lungs, they're going to constrict. And that's not good. The reason why they're constricting so much, at least part of the reason why, is because they have angiotensin 2, so much angiotensin 2 related to that ACE2 receptor downregulation. So this increase in angiotensin 2 is going to cause the blood vessels to constrict, and that makes it harder for the right side of the heart to pump. And this is going to ultimately mean less oxygenation than normal. As if oxygenation wasn't a big enough problem already, now we got a third reason why the oxygenation is going to be so bad. Let's review our heart physiology. So the pulmonary vein, this is the blood that's coming back from the lungs. It's going to be oxygenated because the blood that goes to the lungs gets oxygenated there. So now it's coming back, and it's going to go into the left atrium of the heart. Then it goes to the left ventricle of the heart. Then it's going to be pumped out to the body through the aorta. And this blood gets pumped to the body. It's going to go to the brain. It's going to go to the intestines, to the kidneys. It's going to go to your legs, to your arms, to your muscles. More of it goes to your muscles when you're working out.
Let's say you train your biceps. Blood is rushing into your muscles, and that's what we call the pump.
Thank you, Arnold. Now when the blood comes back from the body, from those places that I just mentioned, it's going to come back through the vena cava, the biggest vein in the body. There's a superior vena cava and an inferior vena cava. And that's going to land that blood into the right atrium. Then the blood from the right atrium is going to go to the right ventricle and then to the pulmonary artery. And then from the pulmonary artery, it's going to be sent off to the lungs to go pick up oxygen again because it's deficient in oxygen. But the problem, like I just mentioned, is now that vasoconstriction of those pulmonary arteries, that's going to lead to less blood flow getting to the lungs. So there's less blood flow that can get oxygenated. And so what ultimately is going to happen is you're going to have even lower oxygen levels than you would expect normally with ARDS because of that reason. So there's really three reasons why patients with ARDS have such a difficult time with oxygenation. One is because of all the inflammation from ARDS. Two is because the microthrombi that develop, the tiny little clots that form in the capillaries. And three is this pulmonary vasoconstriction, this pulmonary hypertension that develops. And ultimately, the oxygen levels are just going to drop very, very low. Now, there's a lot of people asking about ACE inhibitors, angiotensin receptor blockers. So ACE inhibitors are things like captopril, lisinopril, ramipril. Angiotensin receptor blockers are things like losartan, telmisartan, candesartan, irbesartan. Here's how these things work. ACE inhibitors inhibit the ACE enzyme. So there's going to be a blockage in this part of the cascade. And what happens here is if you put a roadblock here, that's going to shift this sequence to this way. All right, it's going to go down that way. Now, if you have a blockade right here in this part of the pathway by an angiotensin receptor blocker, such as losartan, these medications inhibit binding to this receptor here. All right, so if you inhibit it here, it's going to shift everything towards this way and towards this way. And you're going to have this right here. That's good. That's what we want. We want to dilate those pulmonary arteries. We want to reduce inflammation. We want to reduce fibrosis. That's good. So that's why I think the trials that these medications are in right now for COVID-19, I think we're going to have great results with that, but only time will tell. And everything I just mentioned to you about ACE2 and angiotensin 2 and angiotensin 1-7, this is all backed by multiple studies going back 10 years ago or so. And there's even more so in the last couple of years because this is a very hot area of research. And I'll show you some of the studies real quick. You got this one. There's the angiotensin 1-7, how it relates to ARDS, and the type 2 alveolar cells. I mean, there's just lots and lots of studies that have to do with exactly what I'm talking about. So how do we get COVID-19 patients with ARDS? How do we get these patients better? It's going to be a combination of things, including individualizing various ventilator settings, including adjusting the tidal volume and adjusting the PEEP. It's also going to involve trying different ventilator modes with assist control, possibly APRV. It's going to involve proning patients, meaning lying patients on their chest instead of their back. It's going to include the possibility of using pulmonary vasodilators, such as inhaled nitric oxide or prostacyclin or IV epoprostenol, Flolan. It's going to involve the possibility of steroids, possibly ECMO, and of course, the medications that are coming out for COVID-19 that are in clinical trials. And some are more promising than others, and that's going to be the topic of my next video. Okay, so we know that ARDS develops in about 4 to 5% of patients with COVID-19. And all of these people who get COVID-19, the mortality rate is around 1 to 2%. So why do some COVID patients get ARDS and why do some die? It could be one of these reasons, but more likely it's a combination of these reasons. So here we go. Number one, the virus only gains entry into our cells that express the ACE2 receptor. They're located in multiple sites. Besides being in your lung, they're in your mouth, nose, throat, stomach. They're in your small intestine, the colon, skin, not on the outside of the skin, but underneath the skin, lymph nodes, thymus, bone marrow, spleen, liver, kidneys, brain, and one more place.
These nuts on your chin.
Yeah, that's right. They're in your testes, if you have those. All right, number two, it makes sense that if the virus only gets into your mouth or nose or throat, but not the lungs, that it would cause only cold-like symptoms. But if the virus gets all the way down into your alveoli of your lungs, specifically the type 2 alveoli, that's where you're going to have ARDS potentially develop. And by the way, the ACE2 receptors that are in your gut probably explain why some patients end up getting nausea, vomiting, diarrhea. Okay, number three, the amount of virus that you get into your body likely determines how sick you get. This is what we call the viral load, and this was demonstrated in this study. Number four, the inflammatory reaction that occurs with COVID-19 is extremely complicated with lots of different proteins and hormones and interleukins at play. But there are several known genetic polymorphisms of these proteins that make the illness potentially worse than others. A genetic polymorphism simply means a variation on a particular gene. For example, there are genetic polymorphisms of the ACE gene, not the ACE2, but the ACE gene, as well as IL-6. Basically, a lot of it comes down to our genes and sex, because the fifth reason has to do with estrogen. Estrogen is known to inhibit the effects of IL-6, which plays a huge role in the cytokine storm. This might explain why women overall have less severe disease compared to men. See, ladies, aren't you glad you don't have
these nuts?
And the sixth reason has to do with some people are already on medications that might impact COVID-19. For people who are already on an ACE inhibitor such as lisinopril or an ARB such as losartan or telmisartan, whatever, or people who take hydroxychloroquine for lupus or rheumatoid disease, or people who take tocilizumab, an IL-6 receptor inhibitor, are these patients less prone to getting severe illness? My guess is yes. And now I know there's a theory circulating out there about how the virus might be attacking our hemoglobin. The theory is based on this non-peer-reviewed study that showed that the virus in a test tube, not in our body or in animals, but in a test tube, could attack hemoglobin, which is in our blood. Specifically, it's speculated that it might attack the beta-1 chain of hemoglobin in our blood. Even if it could attach to the beta-1 chain of hemoglobin, I can tell you that it's not the way the virus is causing disease. We know this for several reasons. One, we know it binds to the ACE2 receptor and gains entry into our cells that way. Two, we see that with our own eyes, the destruction that it causes to the alveoli on the pathology. Number three, we know that the COVID-19 patients have a low P to F ratio, which means that the reason for low oxygen is because the lungs' reduced ability to move oxygen from the air into your bloodstream. And people who have low oxygen levels due to an issue with the hemoglobin, for example with methemoglobinemia, they have a normal P to F ratio. Patients with methemoglobinemia have a low oxygen saturation, but a normal P to F ratio. In COVID-19 ARDS, these patients have a low P to F ratio. Okay, number four, the red blood cell does not have ACE2 receptors located on it, so the virus is not able to invade the red blood cell. Number five, hemoglobin normally does not exist outside of the red blood cell, except when the red blood cell bursts, what we call hemolysis. In COVID-19 patients, we're not seeing any hemolysis. Therefore, there's no way the virus is able to attack hemoglobin, except for perhaps a very tiny bit of hemoglobin that can exist in the alveoli as a result of the alveolar damage from ARDS.